Hello, everyone, and thank you for joining us for the Skilled Nursing News Therapy Summit. I'm Amy Stulik with Skilled Nursing News, and I'll be moderating today's session. Physical performance is more important than medical diagnosis when predicting rehabilitation outcome. Before we begin, I want to say thank you to our thought leadership sponsors, Infinity Rehab, Aegis Therapies, and our awareness sponsor, Net Health. We welcome questions from the audience at any time, so please submit your questions via the Q&A function in Zoom. And if you miss any of the sessions today, the recordings will be posted at the conclusion of the series and will be available for 30 days. Today, we're joined by Patty Sheets, Vice President of Quality and Compliance at Infinity Rehab, and she'll be walking us through how providers can use data analytics to describe different group characteristics in rehab patients and recognize factors contributing to treatment responsiveness. So Patty, take it away.
Great. Thanks a lot, Amy. It's nice to be here, and good morning, everyone. Just before we begin, just to give us a little bit of information about Infinity Rehab, we were founded in 1999 and are based in Tualatin, Oregon, which is outside of Portland. We serve over 200 post-acute settings, including skilled nursing, assisted living, independent living communities, home health agencies, outpatient clinics, and wellness programs. And we are in 18 different states. We're proud to be a certified Great Place to Work employer, and our mission is to set the standard in rehabilitation for successful aging by delivering the best of science with the art of caring. And it's that best of science part that we'll really be focusing on today. So our objectives for the session are to really share a bit of information about a large-scale performance improvement project that we started a number of years ago, and what including some robust data analytics. From these analyses, I'll describe the characteristics of different groups of rehabilitation patients that we've identified in skilled nursing, and I'll share with you the factors that we've identified as important in determining responsiveness to rehabilitation. I'll describe then how we use this information to guide treatment selection and interdisciplinary planning and care transitions. To begin, I'd like to talk in a global way about rehabilitation interventions. Rehab providers learn a number of therapeutic strategies to assist patients with activity limitations and participation restrictions, and we can generally group these around these 4 pathways. Remediation, where we're really treating the cause of the activity limitations, largely seeking to improve impairments in body structure and function. And in these situations, when patients can be responsive to these types of interventions, they have the potential to achieve maximal consistency, efficiency, and flexibility or adaptability of performance. Going down the compensation pathway, though, rather than improving the cause of the activity limitation, we are teaching individuals strategies to compensate for that limitation. In their simplest form, these can be short-term things like teaching someone how to get from place to place or to transfer without loading a limb in the case of a fracture, or they can be more long-term strategies for those individuals whose impairments in body structure and function may not recover. Adaptation is really a continuum with compensatory strategies, only to a larger degree. With both of these pathways, the individual usually has to give up some flexibility in performance or adaptability in order to gain consistency, largely for safety, or gain efficiency with that activity, decreased energy demands. And finally, the prevention pathway are those strategies that we employ to essentially put ourselves out of work to prevent decline in mobility, activity, and overall health. Now, when we look at the science of rehabilitation, there's been much more study and research around these remediation and prevention pathways than we see in the science for compensation strategies and adaptation pathways. So, as clinicians, we are able to use more evidence-based strategies, things that inform what we do based on external literature. And when it comes to compensation and adaptation, where you rely more on experience or best practices. Excuse me, I need to move things around here to get this to advance. Okay. At Infinity Rehab, what we have done is we have dug into the science of rehabilitation to identify interventions for which there's a large body of evidence. And we've organized these into what we call our clinical model. And we've used these 4 pillars: intensity, patient self-management, prevention and wellness, and tailoring care to cognitive need as really an organizing principle to kind of frame up, both for ourselves, our clinicians, and our patients, what it is we're trying to accomplish in rehabilitation and how we're trying to bring in that best of science with the art of caring. I'd like to take a few minutes to talk about this first pillar, the intensity pillar, as the concepts around intensity has been one of the most dramatic shifts in understanding that we've learned from rehabilitation science in what really matters to individuals who receive rehabilitation services. So in rehabilitation science, intensity refers to challenge, not amount of therapy. And that's a really important distinction in skilled nursing and in other post-acute settings where we've really tended to focus more on amount of therapy. So if in rehabilitation science, intensity refers to challenge, then what we're really thinking about is how do we use intensity to help patients maximize their gain? Now, it's rather intuitive that in rehabilitation, we're going to do things that are harder for individuals than what they do on their own. That's actually not the big aha from the science. But what the big aha from the science is that it's not, the care needs to not just be a little bit harder than what patients need to do, what can do on their own, but it actually needs to be a lot harder. It needs to be significantly more challenging than patients' self-selected activity in order for it to help patients maximize their gains. Now, in doing this well, every therapy session then needs to have a specific intensity target. That's our entire goal. Our entire purpose is to help the patient work at that level of intensity that's going to be sufficiently challenging them to actually maximize their gains. We don't exactly know about the dosage on this. It's still a question that is being answered in the science. But generally speaking, when you look at the interventions that are being provided, the goal has been to target these high intensity interventions 4 out of 7 days. And I think this is a really important thing for all of us to know and understand, is this is not yet usual care in rehabilitation. There have been a number of observational studies that kind of tell us what is usual care in post-acute rehabilitation, and we are not yet consistently delivering on this intensity principle. So let's talk a little bit more about what this actually means. There are multiple ways that you can measure intensity when it comes to rehabilitation in order to apply this principle of intensity. And we've selected 2 ways. One of the ways is through strength training. And the evidence for older adults is that resistance training or strength training, in order for it to be maximally effective for older adults, should be in that 60 to 80% of the 1 repetition maximum, essentially starting at 60% and really progressing to 80% of a 1 repetition maximum. Well, what does that look like? 60% of a 1 repetition maximum is a task or activity that an individual can do about 13, maybe 15 times before reaching biomechanical failure. 80% of a 1 repetition maximum is a load that a patient can do or an individual can perform 8 to maybe 10 repetitions before reaching biomechanical failure. Now, in this video clip, you're seeing a patient getting to that biomechanical failure using a sit to stand task. Some important things to note: she's not using her upper extremities, because using upper extremities is a compensatory strategy for lack of strength producing capacity. And we don't want her to compensate for that inability. We want to challenge that ability. She's also doing this from a very low surface. And these were the conditions that we had to bring this task under in order for her to reach that biomechanical failure after 8 good repetitions. In this particular clip, Patrick is doing a different task, a getting in and out of bed task. And again, I want you to take note of how we've removed some of the compensatory strategies that we often see in inpatient care. We're flattening the bed, we're lowering the bed rails so that the patient can't use those compensatory strategies. And in order to increase load for the task, we've added a weighted vest for this individual in order for him to reach, again, that biomechanical failure in 8 to 10 repetitions. Our general goal is to do at least 2 activities to that level of intensity 4 out of 7 days. Let's look at another way that we traditionally and are systematically measuring intensity, and that's by looking at heart rate, particularly with aerobic training. And here what we're trying to do is get the heart rate into the moderate to vigorous training zone, and we use a heart rate reserve formula in order to help us determine what that should be for each individual patient. We find that most skilled nursing patients are challenged to do anything at a continuous level. So we always start with 3 continuous minutes to begin. That's our initial training duration. So again, we're trying to identify an activity. The goal is to do an activity that does indeed get the patient's heart rate up into that moderate to vigorous training zone. So in these images, I'm illustrating for you an OT task. It was a laundry task. She was folding. And what we did in order to increase the intensity is the patient is doing the task in standing. We were encouraging to get her arms up as high as possible, as that increases demand as well. And in the first 3 images, she gets through 3 continuous minutes, but her heart rate is still in the light training zone. So we weren't successful in reaching our exercise target, which was that moderate to vigorous training zone. And so in the last figure here, you can see we added wrist weights to her, and now she was able to get her heart rate into that heart rate training zone. And so this is where we would start then in the next session. Another way that we do intensity and by using heart rate is to do interval training. And so in these figures, we see an individual doing walking on the left, and then she's doing a brief running trial on the right. These principles of interval training can be applied to walking tasks. It doesn't always have to be running to be the fast zone, the fast pace. That's a matter of fact, that's unusual for that that to be what's going on, but more what it might be is it might be faster walking with or without a device. It, again, in order to increase the energy demand of the task. And what we're trying to do is build to 20 continuous minutes. And you can use these interval training principles not just with the walking task, but with other tasks as well. A slow bout followed by a brief or short bout, a slow bout followed by a brief or short bout. And again, trying to do that level of intensity at least 4 out of 7 days. Patrick Hennessy and I, one of our clinical knowledge brokers, have been fortunate enough to have been able to participate some in the research around high intensity effort and synthesis documents. And so Patrick was able to be a research therapist working on a high intensity stepping intervention, which has really has been shown to be very effective for all kinds of individuals, including those with neurological conditions, as well as a generalized older adult population. And I was pleased to be a part of a group that developed a clinical practice guideline around locomotor training. And one of the big findings in that clinical practice guideline is this idea about intensity as measured by heart rate. So why does it actually matter, you might say? And we talk about this a lot with clinicians. We talk about it with our customers. We talk about it with payers. Why does this matter? So we've tried to illustrate this big why on using this graphic. So if you look at the red flags on this mountain, what we're really showing is how far up the mountain can a person get in response to rehabilitation. And all of these figures on the mountain demonstrate, based on net level, what kinds of activities you get to pick up if you get further up the mountain. That's kind of the idea. The further up you go, the more activity capacity you have, as well as the more physiological protection the individual has from adverse events, including things like falls, mobility decline, hospital admission, and even mortality. So let's look at the details here. Jennifer Stevens Lapsley is a researcher, and she's quite interested in what's going on in skilled nursing. And she published some work that really reported what was usual care in skilled nursing. And so these red flags represent, on average, where patients in her study were at admission in skilled nursing. And we are using walking speed as the outcome measure of interest here in our graphic. And then the second red flag represents where those individuals were at discharge from skilled nursing. And again, this is usual care. And what you can see is that when you look over at the levels, that the things that are achieved, is that we're reaching, in usual care in skilled nursing, we're reaching a level of independence with activity limitations essentially needed to go home. But in this study, we were falling short of a level of walking speed, or they also use a short physical performance battery and a level associated with reduced fall risk. The average discharge values on those measures were actually lower than would be ideal. So we're in usual care in this study, we were still discharging patients. They'd reached some improvements in physical independence with activity, but they hadn't gained enough physiological capacity and reserve to actually be protective for them for fall risk and hospitalization. Now, moving up the mountain graphic, the first green flag represents some of our own internal data in pilot work, where we had our occupational therapists consistently provide a suite of interventions on that patient self-management pillar that I showed you earlier. And what we saw was significantly more gain. So that green flag is planted on where the average discharge walking speed was for those individuals. So we saw significantly more gain than usual care from skilled nursing, providing a suite of interventions designed to improve patient activation and engagement. And that next green flag represents where we got with pilot work with doing the high intensity stepping intervention with our own patients in skilled nursing. And so what you see is that when we systematically apply these interventions for which there's significant evidence, we get significantly more outcome from patients than what's been documented in the literature from usual care. And again, the key piece of this is that as you go up that mountain, what the patients are gaining is that physiological stuff, if you will, that's actually going to help them prevent decline, mobility risk, fall risk, hospitalization, and even mortality. So let's now kind of take all of that information and put it in the context of value and PDPM. And so we've really been living by this equation that was put forth by Michael Porter about value in healthcare, where value equals quality as we define by outcome divided by cost. And so let's think then about what that might mean as we move forward through PDPM more toward a value proposition in healthcare reimbursement and delivery. So I'm back here where we started, where we're looking at these pathways. And I spent quite a bit of time talking about that intensity pillar, which is really one of those interventions largely around this remediation pathway. But we also know that not all patients have the physiological capacity to respond to these high intensity remediation based interventions. We know that we have some patients that will need not just short-term compensatory strategies, but they will need long-term compensatory strategies. And so in the context of value, what we're really trying to think about is how do we make a match? How do we get down the right pathway for the right patient in order to deliver on that value proposition? So in order to explain how we're trying to answer that question, I want to take just a couple of moments to explain some information about the measures that we use for all of our skilled nursing patients. So we collect measures of activity limitation, which would essentially be our section GG measures. So we're all collecting that in skilled nursing. In addition to that, though, we are using what's a short physical performance battery and a 6-minute walk test and grip strength in order to get measures that are derived from those things around functional strength, activity tolerance, overall strength, walking speed, and fall risk. And you can see on this slide the measures that we're using. Some of them are components of the short physical performance battery. Some of them are derived from the total score or the 6-minute walk test. In addition, we'd use the St. Louis University mental status examination to stratify our patients based on cognitive performance. So what we have done is a data analytics strategy called cluster analysis. And we have done this a couple of times in our data. And just so you know, what we've done with the data then in addition is we do the analysis, understand what the groups are. And we're going to take some time here today to look at these different groups of patients. And then this is also the foundation for a predictive tool that we use in clinical practice, where based on the evaluation results, we can see with about 80% accuracy what group the patient should belong to. So I'm showing you here the proportion of these 5 different groups of patients that we have in the data set. And we're going to dig in a little bit more in describing each of these different patient groups. So let's take a look at this first group. The first group of patients is the highest functioning group of patients. And as you see, as we look at a number of factors, these individuals come in really doing quite well overall, given that they're needing an inpatient stay for rehabilitation. I think the other thing to note is they're about 8% of our population. The next group is the group that's lowest functioning at admission, but these individuals change, and they change a lot. And the critical thing when we look at where they land by discharge is we need to be sure that these folks get over some of those critical thresholds, that walking speed associated with reduced risk for hospitalization, a score on an SPBB that's associated with reduced risk for fall. We want to be sure that before they go leave the inpatient environment, they've reached those critical thresholds that's actually going to ensure that they can be safe and stay where they are and continue to progress. The next set of patients are our non-ambulatory patients. These patients largely improve as well, and some of them need short-term compensatory strategies and some long-term. Our next group is our limited ambulation capacity group. I call these the hanging on to by a thread patients, and you'll see why as we look at more of the details of these patients. This is our largest group of patients. And finally, our limited to no change group of patients. And you'll see in just a bit that they have a high risk for discharge to places other than home. When you do a cluster analysis, it spits out for you the feature importance, those factors that are most important in assigning a patient to a particular group. And what you can see in this figure, the relative importance is on the x-axis, and the features in order of importance are distributed there on the y-axis. And what you can see is that, can you get in and out of a chair without using your hands? How far can you walk if you have 6 minutes to walk? And how fast do you walk over a relatively short distance? Those three features are the most important features in assigning groups. And as we go through, you're going to see these groups are strongly related to the overall outcome from rehabilitation. Those three factors surpass the importance of basic mobility measures and self-care measures, which we're capturing in our section GG. They also surpass the importance of a patient's cognitive ability and their age. And I think this is especially important, they by far surpass in importance what the patient's health condition or medical diagnosis is. So we're all the way down here in the 13th position, and you can see how short that bar is compared to the length of the bar for 5 times sit to stand. We're all the way down here in this 13th position before we come to our first medical diagnosis that's important in group assignment. And when you look at the set of these medical conditions that are important, half of them are neurological in nature. So what we're going to do is I'm going to share with you some more of the details of each of these groups. But before I do that, I want to talk just a little bit about some of the differences that we've seen since PDPM and since COVID. And I would say this is largely, well, it's probably due to both of those things. It's hard to separate the differences among those two different things, isn't it? The key things that I think are important to take away is this, what's happened differently in this highest functioning group. For one thing, in our highest functioning group, what we are seeing is their cognitive levels are proportionately a bit lower than they were prior to the PDPM and prior to COVID. And then the biggest finding is that there are so many fewer of them, a decline of about 17% proportionately are in this highest functioning group now compared to prior to COVID and PDPM. The other area that I want to draw your attention to is this yellow group, this limited ambulation capacity group. These patients do change, but they change to a smaller degree. And there are more of them now than there were prior to PDPM and prior to COVID. And so think about how just this shift in proportion of patients, we have so many fewer patients who are kind of flying over the bars of measurement, if you will, and so many proportionally more patients who are barely hitting measures of critical performance. And think about how that can impact our collective measures, quality measures within skilled nursing. So let's look at a bit more detail for each of these groups. I want to first orient you a bit to these slides. We'll move through them fairly quickly, but I just want to orient you to them. So across the slide, across the top, we're starting with our lower functioning group, our limited to no change group, and moving across to the right and then down to our highest functioning group on the bottom right. In each figure, the darkest color shading will be the highest level for that measure that we're talking about. The lightest shading will be the lowest level for that. And each figure will show you proportions of each of those dynamics for whatever measure we're looking at. So in this particular slide, we're looking at the proportion of patients in the top, middle, and bottom third on the SLUMS cognitive measure. And a couple of things to highlight: there are patients across all three of those subcategories on the SLUMS in all of the patient groups, with more of our patients moving into that medium category, that middle category in our yellow and our red group, which again are our lower functioning patients. Let's look at prior living situation. You can just kind of glance at the figure to see, do these circles kind of look the same or do they look different? And when I glance at them, I see a lot of similarity between our green group and our blue group. The yellow and the red group kind of look similar to each other, but they're a little bit different than the other three. And what we're showing here is, again, the proportion of patients who are prior to coming into skilled nursing, living at home in the darkest color, assisted living in the middle, and long-term care in the lightest color. But let's look at what happens by discharge. Now our groups start looking quite a bit different from one another compared to their relative similarity at baseline. Still, our highest functioning and lowest functioning at admission, but change a lot groups, our two green groups, are looking fairly similar to one another. By the time here we see our non-ambulatory group having fewer patients discharging to home. But I want to really draw your attention to our limited to no change group, this red group. Here you're seeing less than half of these patients are discharging to home. And what I would say is that it's a pretty good likelihood for these individuals, and we can identify these at evaluation. We can pretty much say it's a strong likelihood that these patients will discharge to a setting that requires a higher level of care than they were in prior to coming into skilled nursing. If we look at initial basic mobility, here our light shade are those patients who need a lot of help, our medium shade a little help, and you see hardly any of the dark shade, those patients who need no help with basic mobility. And that makes sense, because this is why patients get admitted for inpatient care, is because they need assistance with basic mobility and self-care. And for time, I did not include our self-care figures, but they followed the exact same pattern that we see for basic mobility. And you can see, though, again, looking at that red group, and to a certain extent that yellow group as well, how much more of them need a lot of help when they come in to skilled nursing. At discharge now, we see a little bit more emergence of that dark color. These are the patients, that dark shade. These are the patients who don't need help by discharge. And we're seeing that represented nicely in our bottom two groups, our patients who are changing quite a bit to a certain degree in our non-ambulatory group. But when you are non-ambulatory, or either short-term or long-term, that certainly does create mobility challenges. And we're seeing that reflected here, with most of those patients needing a little help at discharge. And then again, looking at that red group, the vast majority of the patients still requiring a lot of help at discharge. And that's something that's really important for us to keep in mind as we think about managing, particularly those patients. Here we're showing advanced mobility. Advanced mobility are things like stair climbing. As a physical therapist, we really love stair climbing because the capacity to do it, whether or not you have stairs at home, the capacity to do it is such an important physical marker of performance. So this includes stair climbing, picking objects up from a floor, walking on variable surfaces. And as expected, across these groups, they look pretty similar. This is hard for folks when they come into skilled nursing. And by discharge, again, we see our bottom two groups beginning to pick up more capacity. They're shifting more from needing a lot of help to needing a little bit of help, with a few of those patients now being able to do these more challenging tasks without help at all. So now let's look at the overall change. In this figure, what we've tried to do is take movement on the activity limitation scale of one category, as well as look at the MCIDs of change, that minimal clinically important difference. How many of those chunks of improvement do we make on our other measures? And I've tried to meld them all together on average so that we can see, when you put all the measures together, how much do these different groups of patients actually change while they are with us in skilled nursing. And you can see quite a bit of variability among the group, with that group that is low at admission but change a lot, that dark green group really standing out for the amount of change that they make during skilled nursing. And then that limited to no change group, that red group, really standing out for the little change that they are making during skilled nursing. So now let's come back to this value proposition and think about how we can look at this value proposition idea in light of the measures that we have shared. So what we've started doing is kind of developing our own internal value metric, where for this quality or this outcome piece, we're putting the numerator is our change value of a particular metric, so that discharge value minus the initial value divided by, and what we're using as a representation for cost is hours of physical and occupational therapy together. So I hope that makes sense. We're going to look now at some of the value outcomes on some of these particular metrics. So let's first look at activity tolerance. Now remember, our measure of activity tolerance here is the 6-minute walk test. And our patients who have limited to no change and our patients who are not walking essentially score a 0 on this test, both at evaluation and at discharge. So they are coming right in at that change per hour of 0. But let's look at the other 3 groups. If we're doing well on the value proposition, what we would see is fairly consistent length of these bars, a fairly consistent value ratio, where we're matching well the amount of change that the patient makes to the amount of care that we are providing. That would kind of be the idea. And what you see here is, when it comes to activity tolerance, this is a really difficult measure to really move significantly in skilled nursing. And I would say has been impacted certainly by COVID and just our ability to have patients out of their rooms more. So as we return to more normal situations relative to patients being able to be out, move more, have a drive, a reason to move longer distances, we're hoping to see some recovery in this activity measure. But even before COVID and before PDPM, what we saw was that when patients discharged from skilled nursing, this was still an area that was challenging for patients and one that we expect to continue to improve for those patients who get follow-up after skilled nursing care. And that would be the case, particularly in that dark green group of patients. Our patients generally were achieving about 1/3 of normal on this test based on age and gender. And then we see our patient with our limited capacity for ambulation. This is the group of patients that we don't think will respond well to those remediation type interventions. And we're seeing that in this value metric. Let's take a look at fall risk. And here what we're seeing on those two groups, again, I should say in this measure, we are using our total short physical performance battery that requires standing and walking. So again, because of the measure that we're looking at, for our limited to no change group and our non-ambulatory group, these patients come in at 0. So when we look at the other measures, however, we see much more evenness, if you will, in that length of that bar and that value metric for our green groups, our highest functioning group, and our low performance of admission but change a lot group. And we're doing a bit better here with our limited walking capacity group of patients. And this is a group, though, that often when they're discharging, though, when you look at their values on some of the metrics, they are falling into that range where they are still at risk. They're at risk for fall, they're still at risk for potential hospitalization, they're still at risk for further mobility decline, and hence why I often think about these patients as our holding on by a thread group of patients. But now let's switch gears a bit and look at our measurement of basic mobility. And how are we doing in the value proposition for basic mobility? Now here, and I want to be sure that I've kind of made this clear, when we think about building activity tolerance or building, reducing fall risk, and we're typically doing that by building capacity in the balance system performance, building strength, movement speed, all of that helps reduce risk. On those measures, the patients that we're expecting to really change the most are patients who we are expecting to be responsive to those remediation type interventions, that intensity pillar that I was referring to. And so for our patients, that's really that the highest functioning group, our green groups here, our highest functioning group, our low at admission but change a lot group, and to a certain extent, our non-ambulatory group. But then in other measures like basic mobility, here, when it comes to mobility and self-care, we can employ not only remediation strategies, but we can also use compensatory strategies. And so if you can't get from here to there by walking, let's try a wheelchair. And can you get from here to there using a wheelchair? And can you do that on its own? That's kind of a basic concept related to those compensatory strategies. So when we employ compensatory strategies, which we can do here with our basic mobility measure, we see a lot more consistency across these bottom 4 groups in our value metric. So given the amount of change that we're making relative to that cost that we are representing by hours of PT and OT, we're coming out pretty consistently in all of the groups except that red group. And this is the group that even when we employ our compensatory strategies for these patients, they still are not responding well to rehabilitation from any strategy. They're not responding well using that remediation pathway. They're not responding well using that compensatory pathway. Even when we dip down into the adaptation pathway, they may not be responding as well. And so what we're really thinking about here is that prevention piece with some adaptation, really around caregiver training, trying to think about what are the life roles for these individuals and how could we potentially maximize their participation through adaptation in life roles. And so you really see the difference in the value proposition across all of the groups, I think, in this particular slide. And as I mentioned, self-care looks very much the same. So then if we take that one step further, and this is the last figure of the morning for this presentation, if we take that one step further and we think about, given these differences in responsiveness to rehabilitation that we see in our patients in skilled nursing, how do we work through getting this right care to the right person at the right time? And so I've talked a little bit about the use of that remediation pathway and the need to do that to its fullest capacity for those patients who can be responsive to that. And I've also talked about using that compensatory strategy. So we've talked about kind of the type of care. What about when we think about amount of care? Because this is, again, one of the ways that we've traditionally thought about rehabilitation in skilled nursing. And so in this figure, what I'm showing you on the x-axis is length of stay, and the average weekly treatment minutes are on the y-axis. And what you can see, if you think about the amount of change that the patients make, and we're just going to use basic mobility because that's our measure that most patients will improve on who come to skilled nursing. If we use, that's our most liberally changing measure. If we use that and we try to get some sort of right size of care when it comes to value, you see that for that group that not change hardly at all, that red group of patients, a pretty significant difference in the indication for amount of care for those patients in this value-driven world, with much more similarity in the other groups. And I want to be sure that I point out that dark green bar, those patients are the patients that, in my view, need our most attention from a rehabilitation perspective. They will be responsive to our care. They need that remediation intervention, and we need to ensure that they reach those critical thresholds that are protective. And one of the challenges that I think happens in rehabilitation care when we don't take this from like an individual patient, or in this idea, these groups of patients, if we don't take into consideration some of these differences, what happens is we just give everybody the same. And that's what we're trying to move away from as we think about this value-driven world. Well, what does that mean? What are the implications for the interdisciplinary team? One of those we would suggest is to focus more on quality than on quantity. And what we use all the time is do the care that's at the highest level of intensity that's safe for the patient. And when the prognosis for remediation is good, being sure that we deliver enough of that, that we get the patients over those critical thresholds. And I'll tell you, one of the things is starting that care right out of the gates, doing that, getting that higher intensity going right away in order to prevent adverse events. And I think there's a lot of opportunity to collaborate with payers on understanding around this. And when that prognosis for remediation is poor, especially even when that prognosis for responsiveness to compensatory strategies is poor, what do we need to do? So for that red group of patients, what do we need to do? It's really about early planning, early communication, early out of bed programs, and watching for early warning signs related to potential risk for hospitalization. One of the things that we've begun trying to do is think about how to have these conversations both as an interdisciplinary team, as well as clinician to patient and with families, and really trying to, we hear a lot about, well, I don't want to give up on the patient. And one of the things that we worry about is if we provide care that patients are not responding to, will that limit our capacity to actually treat those dark green patients, right? To actually help those patients reach those critical thresholds. So trying to match the care to the patient's anticipated responsiveness. And so it's harder for these patients who are likely to discharge to a level of care where they need more care than they did when they came in. And so what we try to do is use data. And so this is an example of an evidence-informed sheet that we've had about factors associated with likelihood of walking. So let's just talk through, based on the external literature, what is needed in order to walk, and let's see how you're performing. Thinking about how do we maximize participation for these individuals right now, and on our prevention and wellness pillar of our clinical model, we've really been trying to focus on these 4 M's that the Institute for Healthcare Improvement has really been important in promoting, about what matters to the individual, their medications, what's going on with their cognition and their mobility. So I think this is kind of where we are in trying to think about how to respond to this value-driven world, to take the data and the things that we've learned from our patients, put it into some predictive modeling, and then use it in decision-making for clinicians when they're providing care, as well as bringing in some of those perspectives to that interdisciplinary or interprofessional conversation. So that's what I have for you this morning. And at this time, I'm more than happy to answer any questions that you all might have.
Well, thank you, Patty, for that great presentation. And yes, we do have some time for Q&A. So I just wanted to remind everyone that if you have any questions, feel free to submit them and we will get to as many as we can. Now, the first one here, Patty, so you mentioned that more intensive therapy is not the norm in skilled nursing, and get into a bit more about why that is.
Yeah, that's a great question, Amy. And this is like the $1 million question, right? So the evidence shows that it generally, in healthcare, not just in rehabilitation, takes 17 years for what we know from science to actually be the care that patients receive consistently. That's 17 years. That's a really long time. And because of that, there's actually a whole science now, implementation science, that's been developed, and performance improvement work is often grouped in with that. That's really designed to address that very thing. How do we change clinician behavior? And when you think about human behavior, and clinician behavior as part of that, is you generally have intrinsic motivators and extrinsic motivators when we can think about that. And so, of course, what we try to do with our clinicians is be sure to give them the knowledge, the why, talk with them about skills, to fill any skills gaps that they might have, and then really you were really tapping into those intrinsic motivators, both for our clinicians and our patients and their families, to understand what's the value of these higher intensive elements of care, what they can get from it. The other side of the coin is those extrinsic motivators. And I know one of the things that clinical practice guidelines are beginning to do with payers is payers are beginning to look at some of those clinical practice guidelines and dig in a little bit more, although I think there's still actually opportunity to do more of that, to actually dig in and look at what is being provided. Is it consistent with the clinical practice guideline? And, you know, that's a really powerful extrinsic motivator to clinicians, payer rules. So I think that we're just barely putting our big toe into that side of things, but it's beginning where they're looking for some of those synthesized documents and then using that to say to clinicians, it doesn't look like this was provided. Let's talk about that.
And then you kind of touched on this a little bit, but what is being done about, you know, having intensive therapy be more of the norm in skilled nursing?
Thank you. Yeah. So it's really at this point a kind of an individual effort. What we've done is we've invested quite a bit. We have knowledge brokers who are expert clinicians, and they go in and work side by side with clinicians. They model behaviors. They help the clinicians see where they're hitting the mark with those behaviors and where there's a gap and how they can modify that. So we've been pretty purposeful about building some infrastructure to help the clinicians, again, fill any knowledge gaps, fill any gaps in skills that they may have. And then how do you build that by looking at, always there's accountability. That's always kind of a piece of knowledge translation interventions. And so we can do that through audit, feedback, that sort of a thing. So what we've tried to do, and different folks are doing it differently, what we've tried to do is really invest in the infrastructure and the personnel that can help our clinicians move in those directions.
Mm-hmm. And another question here. So the measures you used in the analysis are different from the quality metrics used by CMS. How do you think your data relates to the measures collected by CMS?
Yeah, so that's a good question. So, we have Section GG that's being used across the post-acute environment. And I hope that you saw in the figure that Section GG is not as robust in identifying these differences in patients. Again, because we can teach compensatory strategies and remediation to get people there, it doesn't identify those patients who really need those remediation strategies to prevent health and mobility decline. And that, to me, is a part of the really big picture. It's about more than just getting the patient out of the community and into, out of the building to home. And so, so I think that what we see is that these measures are particularly valuable. I, of course, am always thinking, well, we could change CMS. And actually, these are not hard measures to collect. So you could think about really looking more at the longest distance walked. That's a pretty good representation of a 6-minute walk test. We look at transfers. We could say yes or no. Can the patient stand without using their upper extremities? And then finally, walking speed. The data on walking speed as an indicator in older adults is so powerful that it's often referred to as a 6th vital sign. And it really is pretty easy to capture, and it wouldn't take actually that much to make some of these measures that are more robust in really identifying differences in rehabilitation measures. It really wouldn't be that difficult to get them embedded into practice.
And then in the title of your talk, you state that physical performance is more important than health condition when predicting outcome from rehabilitation. What role, if any, do you think the health condition plays in responsiveness to rehabilitation?
Yeah, also a good question. I think what happens is that, so there have been a number of studies that have looked at this. So they've looked at comorbidity indices and how that relate to functional performance, and they don't pan out very well. And as a therapist, you can always think of like two patients who have the same set of medical diagnoses and they look completely different. Where I think medical diagnosis comes into play is neurological diagnoses, and we see this in our data. When you have an illness or a condition that's primarily affects the motor sensory system that's needed for mobility and activity, that's going to be a problem. Not always, though. So again, there are some data like stroke that would tell you about prognostic indicators there, so you can dig into that a little bit more. And then the other side that we see is we do see some effect of multiple health conditions, but it seems like it's when more health conditions get to end stage, where we simply, and often we are left to figure this out by response to activity or exercise. When we attempt to get the heart rate up into that moderate heart rate training zone, something goes wrong. The heart rate, the rhythm changes. It goes up too high. Blood pressure changes in an unsafe way. And when we see that over time, that's usually how we're measuring that basically the patient's systems, their multiple systems that are impacted by their health conditions are at a level where they simply cannot be responsive to these higher level of interventions. So that's kind of where we are. And it's actually kind of a big black box of rehabilitation. And I think definitely worth additional study in understanding, are there some factors that regardless will have an impact, or is there a certain, like you have to have 3 conditions that are bad, for example, before it impacts your rehabilitation outcome? That's the type of data that we might need to answer that question more specifically.
Mhm. And then you showed us a figure related to cognitive status in the different patient groups. How does cognition impact the patient outcomes?
Yeah, I showed you some results of some pilot work where we did high intensity stepping with our own patients in skilled nursing, and that was we were able to slice and dice that data by cognitive status. And what we found was there was no relationship to responsiveness in that intervention based on cognitive status. Now, when we aggregate the data over more patients, we certainly see that our lower performing groups of patients have more cognitive impairment, but really what it comes down to is it's therapists and how they change their approach to maximize responsiveness to those physical interventions. So some things that we know help: blocking practice, doing things in the same way, keeping instructions simple and the same. It's really about just gaining skill as a clinician, recognizing that if we build capacity, even with a patient with diminished cognition, it's still protective for them, and may even be more important for them, say for fall risk, where because of their cognitive processing, they might be more at risk. If we can help build the physical stuff to be more protective, then that's really what the goal is. It takes a little more effort. It takes more patience on the part of clinicians, but cognition by itself is not one of those things that says it's absolutely, when it's providing these more intensive interventions is not going to work. That's not the way it works.
So it looks like we are out of time here, Patty. So just wanted to thank our audience for joining us, and of course to you for the great presentation. And then a big thank you to our sponsor for this webinar, Infinity Rehab. And for our audience, don't go too far. Our next session, How SNFs Can Drive Therapy Upside in the PDPM Era, begins in 30 minutes. So see you there.